Welcome to Mission Evolution Radio Show with Gwilda Wiyaka, bringing together today's leading experts to uncover ever-deepening spiritual truths and the latest scientific developments in support of the evolution of humankind. For more information on Mission Evolution Radio with Gwilda Wiyaka, visit www.missionevolution.org. And now, here's the host of Mission Evolution, Miss Gwilda Wiyaka.
Our healthcare system is widely considered to be broken. I won't argue. The trajectory of Western medicine has unfortunately led to a system where insurance companies are the primary beneficiaries, leaving patients and doctors to bear the burden. Is it possible for AI to provide an answer? Might we soon see the fictional medbots become a reality? Is this a path to success or to disaster? Mission Evolution Radio Show is coming to you around the world on the Voice of Canada Broadcast Network, www.vocbn.ca. With us this hour to examine the state of the Western healthcare system and solutions to the situation is Dr. Robert Pearl. Dr. Pearl served as the CEO in Kaiser Permanente, where he led over 12,000 physicians, 50,000 staff, and was responsible nationally recognized medical care of 12 million Kaiser Permanente members. He currently serves as a professor at the Stanford Medical and Business Schools. Dr. Pearl is the author of 2 books on healthcare, Mistreated and Uncaring. Website, drrobertpearlmd.com. Dr. Pearl, thank you so much for joining us.
My pleasure, and I'll add the fact that I've also published a 3rd book, ChatGPT MD, How AI-Empowered Patients and Doctors Can Take Back Control of Medicine, with the proceeds from all 3 books going to Doctors Without Borders.
That's fantastic. That's fantastic, because it's such an interesting topic, an important one. Now, as a medical doctor, what was your specialty?
I fixed children with cleft lip and cleft palate, trained in plastic surgery to be able to develop that skill, and I've done over a dozen mission trips around the world.
That's amazing. So you go overseas to donate your time to fix cleft palates?
Exactly right. Last year I was in the Philippines, and we did 17 different repairs, and in every one of them, the parents were crying when they saw their baby, a child who they thought would have no future, and after an hour and a half of surgery, could have a normal life.
Just an hour and a half makes such a difference. That's amazing. Well, thank you for doing that, sir. So how did you first become interested in AI medicine?
I've always been interested in computers. Even in high school, I'd go to Columbia University on Saturdays and study how to do programming, obviously of much earlier versions than we have today. And I became interested along the ways of what that technology could advance medicine. I was shocked by the fact, and you're not going to believe this, the most common way that doctors exchange medical information in the United States today is the fax machine.
Oh, no.
1934 invention. And I could see the gaps. You know, patients would see multiple clinicians and no doctor would know what the other one did. They'd prescribe medications and no one could be certain they wouldn't have a negative interaction among them. And so I could see so many opportunities. And as you point out, my first 2 books, I talked about the need to evolve, to transform the American healthcare system. I talked about the importance of value-based care. I talked about ways to be able to apply operational improvements so as to increase the health of all Americans, but there wasn't a tool. And then all of a sudden, November 30th, 2022, OpenAI releases ChatGPT, and immediately I can see this is what we have been searching for. This is the tool that can save hundreds of thousands of lives, make medical care affordable for all Americans, and reduce the burnout that is a scourge for both doctors and nurses.
Well, let's go back a little bit. I'd like to be the devil's advocate. You're saying about the um, fax machine being the main way that they communicate and try to keep track of what's happening from one patient to the next, from one doc to the next. But on the other side of that, they've got these patient portals and this and that going. And what I see going on is if I go into the doctor, my poor doc is spending more time hacking away at a computer than he is looking at me, or she is looking at me. And it's like they have to find the diagnosis codes to make the insurance companies happy. And they have to enter in everything that's going on with you so that you go to the major system. And that's pretty disruptive too.
You're absolutely right. And actually, generative AI is already being used in two ways to relieve some of that burden. The first is by ambient listening, being able to listen to the conversation between you and your doctor. And maybe your clinicians don't have it yet, but it's readily available. There's 70 different companies in the United States doing it. And actually, the technology will listen to the conversation and create the electronic healthcare entry so that rather than staring at the computer screen and typing away, the doctor can actually look at you as you desire and be able to do a physical examination because they've been untethered from the computer. And this is saving clinicians time, estimated to be a good hour a day, and in a recent survey, diminishing burnout by as much as 40%. And the other way, by the way, that you didn't mention, except in your introduction, you talked a little bit about it, is that clinicians spend a massive amount of time and frustration battling insurance companies. And now the generative AI tools can provide assistance for them at completing the very complex bureaucratic tasks that insurance companies require in order for doctors to get paid.
Well, it would appear that our doctors have become increasingly stressed and overworked in our insurance driven system. Is there any relief with AI inside for that?
Let me start actually before the AI with the question of why are clinicians so overworked and stressed? And it's very simple. The amount of work that they are given every single day is just too much in the current fee-for-service system. The treadmill just goes faster and faster. I'm sure you saw the fact that Medicare is cutting the reimbursement per patient. So what are doctors going to do? They're going to have to see more patients. On average, they see a patient every 17 minutes. That's not enough time, given the complexity of chronic diseases and other problems that individuals have today. They cut the patient off after 11 seconds because they don't have time to listen to the full history. And we have 400,000 people who die annually from misdiagnoses. The first thing I believe that we need to do is to shift the payment methodology. Because when you move from fee-for-service, which is basically pay for volume, the more you do, the more you get paid. Whether it does any good doesn't matter. You make exactly the same amount of money, regardless of the outcome for the patient, and move to some form of pay for value. I like the word capitation, a set fee given not to an insurance company, but to doctors and hospitals to provide all the care for a population of patients. And when you have that incentive, now you start to focus on prevention, patient safety, better management of chronic diseases. And in every one of these areas, what you see is that generative AI can add massive volume. As soon as you start focusing on keeping people healthier, and I'll give you one statistic that I focus on all the time, and it comes from the CDC, the Centers for Disease Control. And they found that if we could effectively control chronic diseases, we're talking hypertension, diabetes, heart failure, that we could cut the number of heart attacks, strokes, cancers, and kidney failures by 30 to 50%. That would reduce costs by over $1 trillion and save hundreds of thousands of lives every year. And the generative AI tools are exactly what clinicians need for two reasons. Number one, the tools themselves will help clinicians to make better diagnoses, to come up with better treatment plans, but it also will empower their patients to be able to take better care of themselves and help to better control the blood sugars or the blood pressures that produce strokes, heart attacks, kidney failures, and lower limb amputations.
Well, it would appear that we're getting less and less healthy as a nation here, and a lot of it, people I've talked to say, docs I've talked to, it has a lot to do with diet and what's been done to our food, and yet people are addicted to these weird foods. How can AI help with that?
Well, you're absolutely right again that a big problem is the growing epidemic of obesity. What we've seen over the past 20 to 30 years is that excessive overweight and actual true clinical obesity has now grown from about 22% to 46% of Americans. That's almost 50% of people. And what we know is that obesity is the number one cause of diabetes in adults. What we know is that obesity accounts for as much as 40% of all cancers. All of the problems we're talking about, the worsening of health and the growing costs, can be traced back, in many cases, to obesity. So the question becomes, how did we get here and how do we reverse it? Well, we got here because, as you note, the food industry figured out that they could actually provide food that was, and I'll use the word addictive, but it's not addictive the way an opioid or cigarette smoke would be, but it is in that it releases the same brain compounds, the dopamine and norepinephrine, that make you get a high. And the consequence of that is you want more food, which is what the industry wants to sell. So fundamentally, we need to change the economics. And I've encouraged Congress to be able to tax these foods that are high caloric, that are high fat, that are ultra processed, that we know account for this growth in obesity, and to use those money to make available fruits and vegetables. One of the challenges, it actually costs more to eat healthy in the United States today. That makes no sense when you factor in the health consequences. And this is one place where I think a generative AI tool is perfect. And I'll give you an example. Every Sunday night, my wife and I sit down and we ask ourselves, what do we want to eat this week? Maybe we had a couple of very high calorie dinners. We want to go lower calorie. Maybe we want to focus on a particular kind of food. Maybe we want a particular genre, Italian or Mexican, depends upon what we want. And we put that into ChatGPT, and it creates for us.
Dr. Pearl, we're going to have to pick up on this on the other side of a station break.
I'll finish after the break.
Dr. Pearl and I will return very shortly, so don't you go away. This is Mission Evolution, www.missionevolution.org.
One people, one nation, searching through the night. One people, one nation, searching for the light. The end has come, the night has fallen. I have reached the end of days. What's real is not, reason fails me. I've gone beyond all known pathways. This is the end of reason.
Whatever happened to the good old country doc? With us this hour, discussing the current state of our medical system is Dr. Robert Pearl, the author of three books actually, Mistreated, Uncaring, and Dr. Pearl, what's the name of your third book?
ChatGPT MD, how AI-empowered patients and doctors can take back control of American medicine.
Wonderful. Now, you were telling us about how you're using ChatGPT to figure out your diet and all that sort of thing. We were talking about obesity and the health problems there. So tell us how you do that.
So, as I was saying, Sunday nights, my wife and I sit down and we decide what kind of food we like to eat that week. Do we want to, bulk up on protein? Would we like to have fewer calories? Do we want to have a particular cuisine? And we put that information to ChatGPT. And by the way, I keep talking about ChatGPT because my book is GPT MD. They flow together, but it could be Gemini from Google, or it could be Claude from Anthropic, or even DeepSeek, the new version, open source version out of China. And ChatGPT gives us a 7-day menu specific to our tastes and desires. It gives us a shopping list. It gives us the menu to cook each of these meals that we'll be having, assuming that there's cooking involved. Now, just imagine if that were available to the parents of every child in this country, and we made the taxing of the ultra-processed foods and use that money to make fruit and vegetables and other fresh ingredients more available, how that would change the dietary habits of our country and the positive impact it would have, not just today, but these are the children who will become the adults in the future for decades to come. There's a tremendous amount that the generative AI tool can do, but it can go way beyond that for the people who have the chronic diseases, because in the United States today, we do a poor job of controlling them. Hypertension, accounts for 40% of strokes. We control it only 60% of the time. Diabetes, the leading cause of heart disease and kidney failure, and 80% of the lower limb amputations, we control that less than half of the time. And it's because the model that we have, the fee-for-service paid model, requires patients to go to the doctor's office. And now with this tool, particularly if we can shift the payment methodology, now we can focus on how do we manage it in the home. A chronic disease is there every day. The traditional model, you go to the doctor every 3 to 4 months, doesn't work to get the outcomes that we need. And this new technology will obviate that problem.
Well, there's the other problem of how long people are having to wait for testing and for results from testing. You could die before you get in to be tested for them to even diagnose you sometimes. And
or even get a referral to a clinician, or have an opening in a clinician, or even be able to find a doctor with the time to be able to take you into his or her practice. No, you're absolutely right. We have modern technology. It would accomplish it. We just have to decide we're going to use it.
So the new financial structure you're talking about, what would that look like for the patient? Do we still buy health insurance? What would that look like for the patient?
For the patient, you would have a variety of options from whom you want to get care. You might decide that you like it at an academic medical center. You might decide that you want to get it from a community hospital with the doctors living close to you. There's a lot of options you would have, and you would opt in. And for that entire year, that's where you would get your care. You would, they would be responsible for a given population. They would be paid more if the people who chose them were older and sicker, or had a lot more diseases that had been appropriately documented. And hopefully you would then decide to stay with those clinicians across the time, so that as they helped you to better avoid, prevent, and control chronic disease, and you had fewer heart attacks and strokes and kidney failures and cancers, they would benefit along with you. So the amount of money they would get would not be based on how often they saw you, but how successful they were in helping you obtain better clinical outcomes, staying healthier. It just aligns every incentive. What did Charlie Munger, Warren Buffett's former colleague, say? Tell me your incentives and I'll tell you the outcomes you're going to get. Pay clinicians on a fee-for-service or pay for volume. You'll get more things done, but not necessarily better outcomes. Pay them in a incentivized system that has them benefit when you are healthier, when you are safer, when you don't come down with chronic diseases or the complications thereof. That's the outcome you're going to see.
And one thing I've noticed is that sometimes, well, a lot of times anymore, our illnesses are so complex and involve so many different parts of our life that your regular doctor can't necessarily track that down, and thus functional medicine has started. Do you see a place for functional medicine in this system?
By functional medicine, you're talking about lifestyle medicine? You have to help me.
I'm sorry, functional medicine docs are kind of like holistic docs. They take into account all the things that, and rather than being specialists, that it's this little piece and that little piece and this little piece, they bring the whole person together and look at it, that picture, and they work with diet and lifestyle and everything else, and they're medical doctors.
Yeah. I think of that as primary care. That's why I was trying to get the clarification from you. And absolutely, we have a problem in the United States today. We've undervalued primary care. We've overvalued the specialist intervention. As you noted, I'm a specialist, so I'm biased in that way, but I still see the basic problem. We pay 100 times more to a cardiologist who unblocks the coronary artery than we pay to the primary care doctor who could have prevented it in the first place if he or she had adequate time and the technology to assist in that process. So that is vital. And I want to make the point, you're asking a very important but complex question, and that is you can't capitate a single doctor. What you capitate is a group of clinicians. That's why I said clinicians in an academic center, primary care and specialty care, doctors in association with the community hospital, both primary care and specialty care, doctors in specific medical groups. And now you have collaboration, you have cooperation, to the point you made earlier, coordination of your care. I often tell people about the time my mom was dying, unfortunately, in a hospital, and I was by her bedside the entire time, and she had a very complex problem, as you're describing. And she had, I think, 5 or 6 different specialists, plus her primary care clinician, and I never saw them talk to each other. They all wrote notes of the chart. Sometimes they were read, sometimes they weren't read. There was no way to know. And to the point you're making, you need a quarterback of the team. And I think the primary care doctor can do that on the outpatient basis. You need to be able to have a team, though, that will all benefit by doing the right thing, by keeping the patient safe. And today, every doctor is just looking at his or her thing. One doctor does your blood, and one does your kidney, and one does your lung, and one does your brain. But the idea that the possibility that all these organs connect, that's not the way that modern medicine is practiced today, but it needs to be.
And between those cracks is exactly where a lot of our illnesses are hiding.
Absolutely. Absolutely. And that, again, is what a generative AI tool like ChatGPT is able to do. As you said, I teach at the Stanford Graduate School of Business, and during the academic year, the students are all there. But in the summertime, they go home, and the university runs programs. And last summer, I was there speaking to 80 CEOs of major companies in the United States about generative AI, because they're all very interested in it and the role it'll play in healthcare. And one of them at the end of the program came up and he said to me, Dr. Pearl, I had never used ChatGPT, but as I was listening to you, I downloaded the app. It's free. And I put in information about my daughter. You see, she had a very complex and difficult to diagnose problem. It took us 18 months. We went to 6 different centers before we finally got the diagnosis. When I put that information into the generative AI tool, the ChatGPT, it gave me a 3-disease differential diagnosis. The top one was the rare inflammatory disease that she ultimately was diagnosed with. I wish I had known this 18 months ago. I could have saved her a lot of time and a lot of pain and discomfort. That's the kind of thing that can be accomplished. It can oversee, under the physician's guidance, the inpatient care, putting together all of the details that these different specialists have provided, pointing out risks, dangers of some type of medical error that no one is seeing because it's between specialties, and it can help to educate the family about what's going on. And that would be a massive advance over where we are today.
How well do you think it'll be accepted among the docs, though? I mean, right now, if you go into your doctor and say, well, I researched online, oh, their eyes glaze over and their backs come up, and it's like, everybody thinks they're their own doctor kind of comment. How do we get beyond that attitude to one where it's integrative with the AI?
I'm so glad you asked that question, because I want to differentiate what happens when you click on, I'll say, a Google link, but a link on a browser against a generative AI tool. You click on a link on a browser, you get a lot of information. You click on a generative AI, you get expertise. And I'm reminded of a story that early on, after I published the book, I was on a podcast, and the host said to me that her husband had fallen. He was skiing. His arm was over his head. He slid down the mountain about 100 feet.
Ouch.
And his shoulder still hurt, and his arm didn't work as well as the opposite side. Now, think about that. You go to Google and you click on, shoulder pain. You'll get 100 diagnoses. You click on arm not as good as the other side, you'll get a different 100 diagnoses. What do? You have no idea what to do. You have a lot of information, but not expertise. I said to her, look, well, she said to me, Dr. Pearl, you're a skier, you're a doctor. What does he have? I said, I think I know exactly what he has, but do me a favor. Download, again, go to the free ChatGPT, put all his symptoms in place, and then call me back and let me know what it said, and I can tell you what I think is going on. 5 days later, she calls me back. She said, thank you so much. We went to ChatGPT and said he almost definitely had a torn rotator cuff.
Mm-hmm.
He needed to have an MRI, and then he needed to see an orthopedic surgeon because he almost definitely needed to have a procedure performed. Think about how different that is. And she said, we went to the doctor. He said, you probably have a torn rotator cuff. We knew what that meant because we had seen the information through ChatGPT. He said,
well, we're going to have to take another station break.
I'll finish when you come back.
Dr. Pearl and I will be right back to continue our discussion. Please stay right there. This is Mission Evolution, www.missionevolution.org.
One people, one nation. I've been broken, shattered, cast to the wind. I am scattered upon the wind. I've been broken, shattered, cast to the wind. I am scattered upon the wind. I've been broken, shattered, cast to the wind. I am scattered upon the wind.
Who broke Western medicine? Can it be fixed? This is Mission Evolution, missionevolution.org. With us discussing the reliability of medical testing is Dr. Robert Pearl. His website, robertpearlmd.com. Dr. Pearl, you were telling us a story about this unfortunate gentleman that slid down the hill with his arm over his head skiing and ended up with a rotator cuff injury. And you sent the wife to ChatGPT to figure out what was going on.
Yeah, and exactly what ChatGPT said would happen is what the orthopedic surgeon did. As you said, he diagnosed a torn rotator cuff. The family knew what the rotator cuff was. Otherwise, they would have had no idea what the surgeon was talking about. He said, you need to have an MRI. They knew exactly why. You wanted to be able to see where the tendon was still attached to the bone or not attached to the bone. He did the surgery as ChatGPT had predicted. And then he told the family, if he'd waited 3 more months, I could not have reattached that tendon because the muscle would have contracted. That is expertise. So this idea that somehow empowering patients is going to conflict with excellent care in the office, it's the opposite. You want an educated patient. Clicking on links on a Google or other browser, that's not expertise. The doctors are absolutely right to come up with a lot of information that's really misinformation. But how does ChatGPT work? It's had downloaded into it every medical textbook, every journal article. It's like having the smartest medical student or resident you could ever imagine, someone who's read everything that's been written in the, I'll say, the scientific literature and forgotten nothing. That is the opportunity that is created by this very powerful technology. And now the patient can become an active participant. One of the things I like to talk about is what's called wearable devices combined with generative AI. So across the street from the business school is the engineering school. They have Band-Aid sized patches that can read your blood pressure, your pulse, your blood oxygen, your blood glucose, all of the parameters that doctors look at. And yet none of them are being used in medicine today. Why is that? Because no clinician wants to be bombarded with 100 blood pressures every day from the many hundred of patients that he or she takes care of who have hypertension. But no, instead what happens is that generative AI tool connects with it using Bluetooth technology and is able to tell the patient exactly how they're doing. And now the clinician sees the benefit, particularly in a capitated system, because it's not a random call. They know the blood pressure is not moving in the right direction. And so it saves them work in the future and avoids complications. I don't think there's going to be any problem getting clinicians to use this. I mean, certainly the younger clinicians are using it every single day. Every medical student uses one of the generative AI tools in order to prepare for examinations, in order to research the literature. And I think when they realize the opportunities to improve their practice and avoid a complication, something that every doctor hates, the thought of harming a patient, takes a vow not to do it. Again, I tell a story about a surgeon. She was in the operating room. She was doing a very, very complex neck surgery, and it went perfectly. She preserved every important structure. The field was bloodless. And at the end of the case, the anesthesiologist said, I can't take the breathing tube out. The vocal cords have come to the midline. They're going to block the airway if I take this tube out. Let's move the patient to the ICU. She took out her phone. She went to ChatGPT. She put the information in place. And lo and behold, there are 4 cases of exactly the same thing. Why? Because when we do neck surgery, complex surgery, we inject a local anesthetic with adrenaline. We're really injecting it because the adrenaline constricts the blood vessels and prevents bleeding so that you can see exactly what you're doing. But in some people, for whatever reason, we don't know, the anesthetic diffuses to the nerves, to the vocal cords, to the larynx, and exactly does this, stops them from pulling apart and keeps them together. And in all 4 cases, within a half hour, the patient recovered. And in this case, that's exactly what happened. She said to the anesthesiologist, let's wait a little while. 20 minutes later, the cords separate and the person goes home. As soon as you've had one experience like that, you see this technology as your best friend, not as a competitor.
So let's talk about how an average person, they've figured out something on I can't say
GPT.
and they want to approach their doc with it. Now, we aren't where you're talking about yet. How would they best approach their doctor? Now we're going into our preferred provider that the insurance company is controlling. How do you approach your doctor with something like that in this day and age? How do we make that bridge?
Well, I think they should think about it as getting a second opinion. You don't go to a doctor and say, this is what another doctor told me. Tell me what you think about the other doctor. You go there to get a second opinion, but you have expertise. You understand what's happening. Had the surgeon, let's say, said, well, you need to have a CT study, and we know that a CT study has a lot of radiation and potentially could do harm and is not as good at diagnosing a torn tendon, the patient could say, what do you think about an MRI? Because they have the information. That's very different than going to a Google link and seeing that there's some,
Right, but
magnetic way of making this diagnosis that has no scientific basis. So I think clinicians will be open to that conversation. Had that CEO gone to the physician and said, have you considered this disease? I think the clinician would have said, no, let me research and I'll get back to you. Because why would they not want to make the right diagnosis? They were just as frustrated as the patient, but they didn't have the time to spend hours in the library researching everything.
yes, but again, devil's advocate, I've gone into my doctor and said, well, instead of this radiation thing, how about we look at a MRI? Well, your insurance company won't cover it unless we do this first. Okay, that's the kind of answer you get. And then, when you have to go through that and you're saying, well, you say this and the doc says, well, I'm going to go research it. Well, he can't. He doesn't have time to research it.
You're absolutely right. That's why I think it's positive. But no, I think you're making a crucial point right now. And I want to emphasize this for listeners. Okay. There is what the doctor does as a great clinician and what the doctor does in a broken insurance system. And the issue of the clinician saying you're going to get a CT rather than an MRI, despite the radiation, because the insurance company will not pay me for this, that's not medicine. That's not physicians. That is an impediment to great care.
Yeah, that's blackmail.
Exactly. And so that battle, I hate to say it this way, needs to be fought in court. And right now, I think a lot of that is starting to happen when it's truly inappropriate. Now, if the doctor wants to do something that is so outside of the general practice of medicine, I would hope that someone would question that. If the patient doesn't know that whatever is being recommended doesn't have any good evidence for it, maybe they're going to do an operation, which they'll make a lot of money, but there's not a whole lot of evidence that's going to do any good. I would hope the insurance company would question that. But where there is a clear advantage, I think the insurance company is making a mistake, actually, when it gets in the middle, because over time it's going to pay a lot more and generate a massive amount of frustration and anger. And we're seeing that build in the United States, as you know, today.
And we have somehow, instead of insurance companies doing what you would think they do, ensure your health, ensure you have the money to do what you need to for your health, they aren't making the decisions based on that. They're making financial decisions. And those financial decisions don't necessarily work in our best interest. However, we live in a capitalistic system. How do we break that chain?
I'll go back to what I said earlier. As long as we're paying people on a pay for volume, not consciously, but subconsciously, we're going to just see more and more volume. And the insurer, who is also, the insurer doesn't actually have any money. It's paid by someone else. Sometimes it's the government. Sometimes it's a business. They have to be stewards of that money. That's an appropriate area to be. But they don't have a tool to accomplish it. The only tool they have is to say no. And so they create prior authorizations and claim reviews. They create a lot of what I think of as friction, a lot of heat, but no movement, to be able to try in their mind to rein in the cost. I don't think it really reins in the cost. But what's the solution? Capitation. Now, it's got to be calculated right. But now you take the insurance company out of it. The doctors, and as I say, it's a group of clinicians, primary care and subspecialists, hopefully working with a hospital, now have a set amount of money, and now the determination is made by the medical experts. The insurance company says, this is the money. If you don't have to spend it because you kept people healthy, you avoided the heart attacks and strokes and kidney failures and cancers, then you can do better. But if you waste the money by prescribing medications that aren't likely to do any good, or prescribing a brand name when a generic is going to be exactly by law equally efficacious, then that's your problem. And so I go back to this idea that when we give the money directly to the clinicians in advance and then hold them accountable for the outcomes, because that will determine the economics of that, we're likely to get far better clinical outcomes than when we ask an insurance executive without a medical background to make these decisions.
Yeah, you got to love that. Somebody that's, maybe has a high school education is choosing whether or not you get the care you need. It's pretty frustrating. So how long do you think it's going to take to get from where we are to where you're talking about?
You are asking not the multi-million or billion, you're asking the multi-trillion-dollar question. And I don't know. I think, I spend a lot of my time studying how transformation happens, how disruption occurs. And the data says that it takes about 30% of a group to change before the rest of the group will come along. If you look at the iPhone as an example, a great technology, it took a certain number of people before everyone else started to buy it. Or the ATM is even a better example. Everyone was afraid the money would get eaten up and they'd never see it again. And how could they trust it? And now everyone uses ATMs. But it happens when enough people tell positive stories. So it's going to take some courageous organizations. And I'm hoping they can do pilots. They don't have to do it for everyone to accomplish this. And I'm optimistic that once that starts, then things will advance quickly. So the real question is, when's it going to start?
We're going to have to hit up on the real question on the other side of a station break. Please stay with us as Dr. Pearl and I continue to explore the future of medicine. This is Mission Evolution, www.missionevolution.org.
One people, one nation, searching through the night. One people, one nation. Brilliant feathers of an unearthly hue glide by on the edge of his dream. A whisper of touch, an unheard song. Those bird takes flight, prompted by his broken heart.
Will this happen in my lifetime? This is Mission Evolution, missionevolution.org. We're continuing our discussion with Dr. Pearl. His website, robertpearlmd.com. Dr. Pearl, just before we took the station break, we were talking about, so this all sounds wonderful. Will it happen in my lifetime? Would you continue with what it's going to take to switch over to what you're proposing?
So moving from a pay-for-volume, fee-for-service methodology of reimbursement to physicians and hospitals to some type of prepayment, I like to use the word capitation, a single payment paid to take care of a population of patients across an entire year. It's going to require, as we said, some people with the courage to innovate. Now, I think the soil is getting more fertile. And I'll say that I don't know if this if the audience is looking at the information from today, but one of the largest insurers, United Healthcare, reported quite a bit of challenge relative to its revenue, and we know it's under a lot of pressure from Congress. We know that the businesses in the United States are fearful now with potentially tariffs coming their way, and they're going to be looking for opportunities to cut costs. I think there are a lot of people out there who might say, we've resisted this for a long time, and now it is a time to actually give it a trial. And I could imagine all they need to do is to find, a few groups willing to, I'll say, do a pilot study with the patients willing to participate. And I predict that if they were to do that and make the investments needed in the technology and the leadership and in the training, what they would quickly find is that the outcomes are not only significantly better, 30, 40% fewer heart attacks and strokes, but also that the costs plummet. And I think that this is the opportunity right now. But you're asking me a question, which is that when will someone have the courage to give it a try? And that is human nature. And you know that is as fickle as I do.
Well, I know that just about everyone I speak to is really frustrated with the way it's going right now. And I'm not just talking the patients, I'm talking the doctors, I'm talking the hospitals. Nobody's happy. Okay. I think it's, I hear more and more and more about a broken system. So do you think that that is going to, can the change be driven from the patient, from the bottom up versus from the top down?
You're absolutely right. First of all, the data says that 70% of Americans believe that the current system not only is broken, but it needs to have major, major change. When I wrote my first two books, I talked about everything that should happen, that must happen. I talked a lot about the patient unhappiness, even back then. We're talking about 7, 8 years ago, when it was fermenting and growing. And what I've learned since then is it doesn't happen until the economics align. So as soon as there are some options and patients can, I'll say, choose with their feet, then I think the patient will have a major voice. But until then, they can't create these alternative payment methodologies, these improved systems of care. And so I think it's going to have to be driven by someone else. The people I think are most likely are what's called the self-funded insurers. So if you look at the United States today, about 160 million Americans get their insurance through an employer. Half of those, so we're talking about 80 million people, the funding of that is directly paid by the company itself to the doctors and hospitals that are there. And I think it's going to be in their interest, and I hate to say this, but particularly if the United States slides into some type of recession or economic downturn, the pressure will grow, and I'm hopeful. That's all I can say. I'm hopeful that someone will have the courage to step forward, because I am convinced that once a few people have done this, that the number willing to do so will grow and will pass that 30%, I'll call it, hurdle. And once that happens, then I can guarantee you we'll move in this direction very, very quickly.
Well, if the companies that insure, provide insurance for their workers are take initiative, that could be a large place to start studies to see how it does go. Yes.
That's exactly what I'm hoping for. But so far, they've been so busy doing all the other things they have to deal with that they've relegated this to the current insurance companies. But I think it's becoming increasingly clear that the current insurance companies are not up to the task. And so again, you and I share the same optimism. The only question is going to be who will step forward first.
How big of a mess, how disruptive is it going to be between where we are now and what you're envisioning?
Unfortunately, I hate to say this, it'll be very disruptive. I mean, Clay Christensen, that we both have read, talks about what happens in a disruptive technology, with the introduction of a disruptive technology. And that's exactly what we're looking at. What's some examples of that? Well, first of all, as I said, you can't capitate clinicians and hospitals unless you can bring together enough critical mass. Well, that requires that doctors be willing to join up with other doctors. They be willing to have a leadership structure capable of implementing changes. It means they're going to change the flow of care from being predominantly office focused or hospital focused and move it into the patient's home. It means that they're going to have to focus as much or more on preventing disease, on maximizing safety, than they are at simply reversing the complications and problematic outcomes that occur, or the diseases that evolve, the heart attacks and strokes and cancers and kidney failures. No, it's going to completely transform it the same way that other industries I mean, just look at transportation when you go from the horse and carriage to the automobile, or the automobile to the car. It happens in other areas where retail, who go back in a generation, and it was all about local stores. And now it's all online. Yeah, these are the changes that happen. They're necessary, but it's very uncomfortable for the people who have been relatively successful to now have to completely uproot what they're doing. But when the economics demand it, it will occur. And as I say, in Clay Christensen's book, he has dozens and dozens of examples of industries completely transformed by the introduction of more modern technology and the change in payment methodology.
Well, again, the problem still remains that we've come to such a place of critical mass. The doctors are so overwhelmed, they don't have time to revamp their whole system.
Absolutely correct. So that's why I use the word leadership as part of the equation, because it's going to require that there be a leader. And that leader could be in a medical group, could be in a health system, could be in a hospital, could be outside medicine. For a while, I thought it was going to be CVS or Walmart. Still could be Amazon. Amazon's very involved with its acquisition of One Medical and its variety of forays into healthcare delivery. I don't think we know exactly where that leadership will come from, but you're right. But then it's going to require clinicians to be willing to take the risk and take the chance. And so, again, in every transformation, one of two things happens. Either you summon the courage to be able to step forward and make the change happen, or someone comes into your industry and takes it over. And I'm hoping that it'll be the clinicians who lead the way.
I hope so too, because nobody knows better what we need than they do. They're the ones suffering under the system as much as the patient. So hopefully people will hear what you're talking about and do something. What all are you doing to get it out there?
Since I published the book, ChatGPT MD, I probably have already given 50 keynotes. We're talking about less than a year. In fact, I was in Orlando yesterday, and I was in Hershey, Pennsylvania at Penn State a couple of days earlier. I'm actually going to be international as well. I'll be in Brazil later next month, and then I'll be in Switzerland the month after that. So there's a lot of interest around that. That's one of the things. And I think probably since I published the book, I've now been on almost 200 podcasts to try to get information out to the audience. And as you note, my website, robertpearlmd.com, has a lot of information, and it has a huge social media following. And my weekly podcast also has about 100,000 listeners to some of the episodes, and that's also available. But programs like yours is how I get it out to a different audience than the one that usually listens to me. And I'm hoping that your audience will join with the other audiences, and together, as I say, to create that 30% critical mass that every major transformational change in history has required.
And that's 30%. It's amazing. It's that low. Where did those figures come from?
Well, a lot of research that's out there. People want to hear more about it. They can read Malcolm Gladwell's most recent book where he talks about it in some detail. But it's in the psychological literature. You have the early, enthusiasts. But it's a small group of people who are expert in that area. Then it gets a little bit wider. And finally, at 30%, you get enough critical mass that others are willing to join in. Well, people who I'd say were hesitant. And then, by the way, when you pass around 70%, everyone does it. And I think about this as the impossible becomes the possible, becomes the inevitable. That's the mindset that shifts. And, finding someone who doesn't have a smartphone today, or someone who's not using an ATM or some other type of electronic financial management tool.
Well, it's that time before we run out of time completely, Dr. Pearl, that I need to ask you, what is your mission?
My mission has been to improve the healthcare of all Americans, and actually people around the globe, but I'll happy to start with Americans. As you noticed, I'm a plastic surgeon. I fix kids with cleft lip and cleft palate. I had about 10,000 patients. By the way, I operated sometimes on the parents and then the children, because the parents got older and the children had the same problem sitting there. I became the CEO, as you said. I took care of a little over 10 million people. And as a consequence of that, I could take care of that population. But now my goal is the whole nation, because I see this suffering. I hear that you and I talk to the same people. They all, because it doesn't matter who you talk with, they're struggling today to get the care that they need. And the health of our nation is lagging. We're 5 to 6 years behind peer nations, despite the fact we spend twice as much as they do. I hear stories at every conference about
Well,
patients who die from preventable medical errors, from
it's
diseases that should have been solved, and they weren't.
unfortunately we are out of time. Dr. Pearl, thank you so much for coming on the show.
Always my pleasure. Thank you so much for being such a great interviewer and host.
Thank you. Our guest this hour has been Dr. Robert Pearl, a professor at the Stanford Medical Business Schools and the author of 2 books on healthcare, Mistreated and Uncaring. To find out more about Dr. Pearl, where you can find his books and all he has to offer, visit his website, robertpearlmd.com. This has been Mission Evolution with Gwilda Wiyaka. For more information or to enjoy past archived episodes, visit missionevolution.org. But please be sure to join us again right here on the Voice of Canada Broadcast Network, vocbn.ca, where this mission will continue bringing information, resources, and support to our evolving world.